Hey everyone, and welcome. I know that studying pharmacology can feel like you're trying to drink from a fire hose. So for this, we are going to cut right through all the noise. We're going to focus on the absolute must-know high-yield points that are really going to make a difference for you on your exam. You ready? Let's get into it. This right here, this is the single most important question in nursing, and it is the absolute key to passing your exam. What is going to kill your patient first? See, it's not just about memorizing a million different drug names. It's all about prioritization. So I want you to keep this question right in the front of your mind as we go through every single medication. Okay, first up, let's talk about rheumatoid arthritis. Now, this isn't your grandma's wear and tear arthritis, okay? This is an autoimmune disorder where the body is literally on the attack against its own joints. So, how do we fight back? We're basically fighting a two-front war here. On one side, we've got to manage the symptoms, the pain with things like NSAIDs, that's your non-steroidal anti-inflammatory drugs, and glucocorticoids. But the real game changer, and honestly where your exam questions are going to live, is over on the right, slowing down the disease itself with DMARDs, that's disease-modifying anti-rheumatic drugs. Okay, methotrexate. This slide is pretty much your cheat sheet for nursing care. This drug is really tough on the liver and bone marrow, so you've absolutely got to be watching their liver function tests, or LFTs, and their complete blood count, their CBC. And a huge patient teaching point, this is not a daily pill. If they report any shortness of breath, that could be lung toxicity, and that's a medical emergency. And finally, this one is a biggie. It is absolutely teratogenic. A positive pregnancy test means you stop that drug immediately. All right, now let's talk about the biologic DMARDs, like etanercept. Because these drugs work by suppressing the immune system, they can actually wake up old, dormant infections like tuberculosis. So here's the non-negotiable rule. You must screen for TB before starting therapy. If that test is positive, you have to treat the latent TB first before a single dose of etanercept is ever given. Anytime we're messing with the immune system this much, there's a risk of something called Stevens-Johnson syndrome, or SJS. And this is not just a rash. We're talking a painful, blistering nightmare where the skin literally starts to slough off. If you see any signs of SJS, the answer is always, always, always the same. Stop the drug and call the provider. Full stop. All right, let's switch gears completely. We're moving from those autoimmune attacks to two very different problems. First, the crazy intense pain of gout, which is caused by uric acid crystals, and then the silent danger of losing bone density. So when it comes to treating gout, you gotta know if you're putting out a fire or if you're fireproofing the house. For an acute attack, when the patient is in agony right now, we use anti-inflammatories like NSAIDs and colchicine. But for chronic prevention, to stop attacks from even happening, we use drugs like allopurinol and probenecid to keep those uric acid levels down for the long haul. Now for colchicine, there is one teaching point that you just have to nail. It has a really narrow therapeutic index, meaning that line between a helpful dose and a toxic one, it is razor thin. So how do we know when to stop? Well, the first sign of toxicity is major GI distress. You tell your patient the second they get hit with bad diarrhea or vomiting, they stop taking it and call. Okay, what about our long-term prevention drug, allopurinol? This is one of those classic exam questions, right? The drug interaction you just have to know. Allopurinol can actually boost the effects of warfarin, which seriously cranks up the risk for bleeding. So if your patient is on both, you need to be watching them like a hawk for any signs of bleeding. All right, let's talk bone health and bisphosphonates like alendronate, which you might know as Fosamax. The number one thing you're worried about here is the esophagus. Seriously. To prevent damage, the administration has to be perfect. It has to be taken first thing in the morning, on a totally empty stomach, with a full glass of plain water, and the patient absolutely must sit or stand upright for at least 30 minutes. No slouching, no lying down, no exceptions. So if the huge risk here is esophageal damage, what's the number one red flag we're looking for? Difficulty swallowing, or dysphagia. This isn't something to watch and wait on. This is a red alert that could mean there's an injury, and it has to be reported to the provider right away. On to our next big battle, the war against viruses. Now, the key thing to get here is that unlike antibiotics, which kill bacteria, most antivirals don't actually kill the virus. Instead, they basically just stop the virus from making copies of itself, which gives our own immune system a chance to get the upper hand. When we're talking about influenza, the flu, there is one number that matters more than anything else: 48 hours. A drug like oseltamivir or Tamiflu is only really effective if it started within those first 48 hours of symptoms. You wait till day 3 or day 4, it's pretty much useless. That 2-day window is absolutely critical. Okay, let's tackle HIV. So remember, HIV is a retrovirus, and its whole mission is to attack our CD4 T cells. Those are like the generals of our immune system. So the whole point of therapy is to suppress the virus, stop it from replicating, which then allows those CD4 cells to bounce back and keep the immune system up and running. So how do we know if the treatment is actually working? Well, we look at 2 key labs. First, the CD4 count. That's your immune system's strength. We need that number going up. And then there's the viral load, which is how much virus is floating around in the blood. We want that number going way down, ideally to a point where it's undetectable. Okay, deep breath. Let's do a rapid-fire review of the absolute red alerts. Let's bring it all together and remember that first question we asked. What will kill your patient first? Scenario 1, your patient on methotrexate calls and says they just got a positive pregnancy test. This is an absolute no-go that can cause fetal death. You stop that drug, period. Scenario 2, your patient on alendronate for osteoporosis reports that it's suddenly hard for them to swallow. That screams esophageal injury. Your priority is to get that reported to the provider immediately. And number 3, a patient who's on the antiviral foscarnet complains of tingling around their mouth and muscle spasms. These are the classic signs of hypocalcemia, or low calcium, which is a dangerous electrolyte imbalance that needs to be treated right away. So, see, pharmacology isn't just a big list of facts to memorize. It's about connecting the drug to the risk and knowing exactly what your priority action is when things start to go wrong. If you focus on these priorities, you are going to be ready for this exam. You've totally got this.